giving you instructions. Can you please make sure that you are listening to the correct channel, selecting the language you wish to listen to? We have interpretation into Spanish, English, and French. At this time, please find the globe icon, which is at the bottom of your Zoom screen. When you click on the globe, you will find the three options and select your preferred languages. Presenters will be presenting in the different languages during this session. Please take the time to find this globe icon. Without further ado, welcome again. We are very pleased to see you and to meet with you again. And I will now give the floor to Dr. Pedro Ordóñez on non-communicable diseases of the Pan American Health Organization. Welcome. Thank you very much, Gloria, for your introduction. I hope that all the colleagues who are listening and hearing and seeing us have the correct channel and they have selected their preferred language channel. Today is November 5, 2021. We are at the headquarters of Paajo. My name is Pedro Ordóñez, and I will be conducting this heart seminar, which is going to be devoted to an issue that we had already announced, innovating in hearts. It is definitely an innovation. It's a change in paradigms. It's a new model, and we will devote today's session to hypertension control drivers in order to improve the control of hypertension. As always, we have an excellent group of panelists. I would like to inform you that we are transmitting this via Zoom, but we are also transmitting via YouTube, and this shall be recorded, so you will be able to share this with your colleagues. And I always say the same thing. If you think that your colleagues are not well informed, please tell them that if we are here, this is a top quality webinar which will be interesting to everybody. As always, I know that we are a little bit better off with COVID now, but as the director of Paajo says, this is not the time to be complacent. Some countries have not made sufficient progress with vaccinations for different reasons, and the pandemic is starting to show that perhaps we took the right steps and we have less cases, but this is no time to be complacent. So in this new situation, we continue preparing to come back stronger, organize the health services, and recovering the time that was lost during these 2 years, which have greatly affected services for chronic disease patients and the issues of hypertension and diabetes, which are two of the main risk factors for serious COVID or to die from COVID, have been the programs that have been really affected. Having said this, today we have a webinar devoted to the key drivers of hypertension. What do we mean by key drivers? This is one of the questions that our panelists are going to try to solve. We have three sections. The first one is going to be devoted to that. What are these drivers? Which are the main drivers for hypertension? And we have three panelists, top class panelists. Then we have a second section. How do we use these main drivers and how do we incorporate them in a system that functions and can be measured? And the third section, we have a novelty. This is the official launch of the course, which is the course on hypertension control drivers. So this webinars, I would like to greet all the people in the audience. I see many people from many countries. Please, if you want to say hello to your colleagues, please say where you are from so I will know. Right now, I'm greeting the colleagues from Peru, from Ecuador, from Uruguay, from Argentina. And there are also colleagues that are saying, here is Suriname. Hello, Suriname is a new member that is going to join Hearts. Honduras, which has not joined yet, but we have Trinidad and Tobago, greetings from Chile. So we start seeing very well-known names of people we are very fond of. We have two professors. One is the president of the World Federation of Heart Issues, Daniel Piñero, and also Dr. Marco Marí from Argentina. I would like to greet them all. Without further ado, we will start with the first section and the first panelist. It is my pleasure to introduce Dr. Jeff Bretler. Jeffrey Bretler is in the south of California in Kaiser Permanente, which has been one of the inspiring models for this session and this innovation. And Professor Jeffrey Bretler, who is a professor at the Kaiser School in California, has been the coordinator and the leader of a group which we call the Innovation Group. So first of all, I will give the floor to Professor Jeff Bretler from Kaiser Permanente in Southern California. Please go ahead with the first presentation.
Greetings. My name is Jeff Bretler. I'm an internist and hypertension specialist, and I co-lead the Southern California Kaiser Permanente Hypertension Program. And I want to thank Paajo and its leadership for the opportunity to present to you today hypertension control drivers and to share the work of the Innovation Group of Hearts in the Americas. And here is my agenda for the presentation today. We're going to start with some background, essentially setting the stage for why this work is so important. We'll define key drivers and process measures and how they relate to each other. We'll give some evidence support for taking an approach emphasizing key drivers. We'll give some examples from the Kaiser Permanente system, and we'll finish with sharing work from the Hearts of the Americas Innovation Group. So let's talk about context now. A call to action is actually the phrase that the United States Surgeon General used last year when describing the current situation in the States, where blood pressure control rates have fallen over 10% in the last 4 years. And the situation globally is not that different. We all know that systolic blood pressure continues to be the most modifiable risk factor for premature morbidity and mortality globally. And when you look at current control rates, there's a lot of room for improvement. In Latin America and the Caribbean, we show here the traditional hypertension cascades in women in the top figure, and then in men in the bottom. So in order, these are patients who are not diagnosed but who have hypertension, patients who are diagnosed but not treated, those who are treated but not controlled, and those who are controlled. So roughly 35% of women and 23% of men. And there's a staggering toll on cardiovascular death in this region, approaching almost 2 million deaths every year. Now let's look at the cardiovascular mortality picture in the region of the Americas. Last couple of decades, we had a nice decrease in mortality in most countries. But if you look at the last several years, there's cause for serious concern, as in many countries, that mortality decrease is now plateaued, and in fact, in some countries, it's beginning to rise. The other important context point is that we now have an updated hypertension guideline from the World Health Organization, really the first one in a number of years. And within this guideline, there are a number of very important recommendations, including when to start pharmacologic treatment, the importance of cardiovascular disease risk assessment, which medications to use, and the importance of fixed dose combination. What should the target blood pressure be? How frequently should we bring patients back? And the importance and recommendation of medication treatment by non-physician professionals. This is a major change in our approach to hypertension, and this work needs to be included in any hypertension work going forward. And the great thing about blood pressure control is we know it works. This is a wonderful editorial in the Journal of General Internal Medicine a few years ago titled Controlling Hypertension. We have the tools, we just need to use them. And this was in response to an article describing new technologies for resistant hypertension. And the gist of the article is we already have the tools. If we use the existing medications that we know are effective, along with behavioral interventions and accurate blood pressure measurement, we can dramatically improve our blood pressure control rates. And these authors actually suggested that using these methodologies, we could reach a control rate of 98%. And there are well-documented examples of where high blood pressure control was actually achieved. So in the Kaiser Permanente system, in this example from Southern California, blood pressure control rates improved from the 50% range to 85%. And in the Canadian experience, blood pressure control improved 50 percentage points over the course of about 2 decades with a very significant decline in cardiovascular mortality. So what are the characteristics of high-performing hypertension systems? What do these systems have in common? Well, I believe in addition to focusing on the outcome measure, which is control of blood pressure, they do the following. They effectively identify the key drivers of blood pressure control. They translate the key drivers then into process measures, and they give feedback to frontline clinicians and clinics about these process measures. So let's take a moment now to define these very important terms. Now, key drivers, also called primary drivers, are system components or factors that drive or directly contribute to the achievement of your aim or your quality goal. Process measures are really the measures of these key drivers, and they typically focus on the care delivered to the patient. The nice thing about process measures are they are directly under the control of the clinic or provider. And then lastly, outcome measures. These look at the effect of healthcare on the status of patients and population, so in this case, blood pressure control. Now, does the key driver approach actually work? Well, this study illustrates this methodology very well. So this study looked at 3 specific key drivers: blood pressure measurement accuracy, treatment intensification, and medication adherence. And they created process measures for each of these 3 drivers and gave feedback back to the clinicians. And what you see here is not only a significant improvement in blood pressure control over the course of the study, but significant improvements in all of those key drivers as well. And here's another great example of the key driver approach. This study posed the question, can the Kaiser model work in lower resource settings? In this case, in a network of safety net clinics in San Francisco. And what the study showed was over the course of 24 months, there was a significant improvement in blood pressure control, which occurred across all races and ethnicities, and also showed increased use of certain drivers, including fixed dose combination medication. What were the specifics of this successful implementation program? And what you see here on the far left are what are called program components, but in reality are actually key drivers, and they are evidence-based treatment protocol, blood pressure check visits led by non-physicians, a standardized blood pressure measurement protocol, patient registry, and performance feedback to frontline clinicians. And what you see here is the San Francisco safety net system essentially adopting these key drivers for their use in their own system. This approach to tracking process measures was actually illustrated very nicely in a recent study published in the Journal of American Heart Association, where they studied 25 fairly large U.S. healthcare systems. So they looked at some of the process measures that were already established to be very effective drivers of blood pressure control. And I want to show what this study showed. I think it's very impactful and illustrative of what the opportunity is. So let's look at a few of these. A repeat blood pressure when the initial visit had an elevated blood pressure was only done 23% of the time. Medication intensification occurred in only 12%. Bringing the patient back in for a repeat visit within 4 weeks only occurred in 35% of patients, and use of a fixed dose combination medication only occurred in 25%. So very large opportunity in all of these areas. And this process measure methodology also really allows you to look at health equities. So this is the same slide, but now with inclusion of race and ethnicity data. And now you can begin to understand why there are disparities in care based upon different process measures, and then turn your focus to those measures that have the biggest impact on control. So let's look briefly at some examples of well-recognized drivers of blood pressure control. So here's the first example, accurate blood pressure measurement. And we know that standardized blood pressure measurement protocols are important. Here is an illustration of the importance of repeating the blood pressure after the initial blood pressure is elevated. Multiple studies have shown similar results, but 34% of initially elevated blood pressures will normalize with a recheck. And in fact, the systolic blood pressure can drop very significantly with a recheck. So just repeating a blood pressure check is an incredibly effective driver of blood pressure control. Now I'd like to shift the discussion to talking about the lessons we've learned in the Kaiser Permanente system. And what I show here are what we've described as the key elements of a successful hypertension program like ours. But the point I want to make here is that these key elements in many cases really are key process measures. So how do we measure blood pressure competently? Are we using a standardized treatment algorithm with a fixed dose combination pill? Are we treatment intensifying? And most importantly, are we measuring all of these systems and processes and giving feedback to the individual providers and clinics? I'd like to continue to show you examples of how looking at process measures is so helpful in improving your blood pressure control rates. So this is a current chart of blood pressure control in Southern California Kaiser. Of course, we had a significant drop with the pandemic, and we've only made up about half of that deficit. So these numbers look a little bit lower. But what you see here is a variation between our 13 medical centers. And the question to ask is, why does that variation exist? So we believe that the variation in control rates, which is an outcome measure, is because of variation in process measures. So I'd like to show you a higher performing center and a lower performing center. And realize that these centers are generally very large, serving up to 500,000 patients. And our hypertensive registry now is almost 1 million patients. So on this slide, we see a high performing medical center, and this is an example of the process measure report that we produce monthly. And it shows 4 distinct process measures: repeating the blood pressure, treatment intensification, a follow-up after an elevated blood pressure, and what we call no BP, which is in our system, if you have not been seen in 1 year, you're considered out of control. So this is a reflection of our outreach and continuity of care. And what you see on the slide here is the high-performing medical center excels in all of these key process measures. So now let's contrast the high-performing with the lower-performing medical center as shown on this slide here. And as you can see, the performance on these process measures is not as good. But what focusing on process measures allow us to do is to really hone in on those areas where the medical center or clinic can really spend most of their time and energy to improve. So in this particular case, follow-up after an elevated blood pressure is quite low, and the continuity of care process measure is the lowest in the region. So it's very easy to talk to this medical center and say, these are the 2 areas that you need to spend your time and energy on. And lastly, and perhaps most importantly, studying process measures allow you to address the issue of health inequities. So let me show you another Kaiser example. We've been working on the black-white disparity gap for the last 10 or 15 years. When we began, it was 7 or 8%. It's now down to about 2%. But we study the process measures to see why we still have a gap. And what we have found is that there actually is no difference in clinic visitation, treatment intensification, or follow-up, but medication adherence is lower in all classes. So this allows us then to address this issue. In this particular case, we did some additional training on communication skills for providers to hopefully improve this process measure. I'd like to now talk about the work of the Hearts in the Americas Innovation Group, and this was a wonderful group with participants from 12 countries shown on this slide. It was multidisciplinary with representation from nursing, primary care, specialty, ministries of health, Paajo, and actual health facility operational leads. The group met every 2 weeks for a little over 1 year, and the focus of the work of the group was really on two HEARTS modules, team-based care and systems for monitoring, with the goal being we needed to identify the key drivers, the key process measures for blood pressure control. We studied multiple high-performing systems, including Kaiser, but others as well. And in the interest of time, I'm going to distill down a tremendous amount of work that was done by the Innovation Group into one key summary slide. And you will be hearing from other members of the Innovation Group in just a few minutes, but here are the key drivers identified with their corresponding recommendations, and they are blood pressure measurement accuracy, cardiovascular disease risk assessment, standardized treatment protocol, treatment intensification, continuity of care and follow-up, team-based care and task shifting, medication refill frequency, and lastly, system for performance evaluation with feedback. In conclusion, to improve blood pressure control, it is really critical to identify the key drivers of blood pressure control. Once you've identified those drivers, we should translate them into process measures and then use those process measures in a performance feedback system to frontline clinicians and clinics. So that's an overall snapshot of the key driver and process measure approach. You will be hearing in more detail about two specific key drivers, the application of this approach in one specific country, and some more detail about the specific indicators and how we scorecard this whole process. I want to thank you for your attention, and I hope you found this information helpful.
Bueno, muchísimas gracias al profesor Jeff Bresler del sur de
Thank you
California,
so
en
much to
Kaiser
Professor Jeff Bretler from the
Permanente en
south
el
of
sur de
California
California.
and Kaiser Permanente in the south of California. We will now go to our second presentation, and I would like to officially welcome. Please remember that we had a group of countries that were confirming their participation in HEARTS, and it is a pleasure to welcome Costa Rica. It is the country number 21 member of the HEARTS community countries. We have El Salvador, Costa Rica, that have joined us very recently. But what is very interesting is that we also have in our webinar the participation of a group of colleagues that do not belong to HEARTS, but I want to mention them. We have colleagues from Venezuela, Puerto Rico, Honduras, Uruguay, and Paraguay, and San Eustaquio. The doors are open to whoever wants to join this magnificent community that is making a difference in the control of cardiovascular diseases. I would like to take three messages from Professor Bradley, and I would like you to jot them down. And please start sending your questions via the chat for our Q&A session. One of the things said by Professor Bradley was, why do some health centers, including in Kaiser Permanente, have better results than others? And what they're saying is that the difference lies in the fact that the centers that have better results, that is to say, better levels of control, have better processes. I will leave this note there for your homework, and you can start asking your questions in the chat. I will immediately give the floor to another colleague who is part of our innovation group. It is Dr. Gonzalo Rodriguez, a young cardiologist from Argentina, who started this process in La Rioja. And today he's going to present one of the most important hypertension drivers. And he is going to talk about a problem that we all have, therapeutic inertia. We will immediately start with Dr. Gonzalo Rodriguez, a cardiologist from Argentina. Please go ahead. Good afternoon. I am Gonzalo Rodriguez, and I am a consultant for the HEARTS Initiative in Argentina. And today I am going to speak about the intensification of treatment as one of the drivers for the control of hypertension in primary healthcare centers. First of all, we will speak about the importance of intensifying treatment, the benefits of the use of a standardized protocol to facilitate intensifying treatment, and the importance of a team-based care approach. When we speak about intensification of treatment in hypertension, we refer to the decisions made and the behavior with those patients that return to the consultation, but they have not met the targets for their BP. And then we need to add a new drug or increase the dosage of the drugs they're already taken. It is interesting to know what we do usually, what does evidence shows. This study, for instance, which was carried out in the United States, analyzed a database of 42 million consultations of patients with hypertension, and it had data from 2005 until 2015. It was published in 2016. What it shows is that the rate of treatment intensification is low for all patients, but it's even lower for those who were already being treated. And although there was a difference amongst the different values of BP, even for values of 160 SBP, it was lower than 30%. And this tended to be reduced with the passage of time. I would like to wonder what would happen if we managed to improve this treatment intensification rate. We can see the results of this study, which was published in 2019, which was a simulation study which analyzed three key elements.
For the control of blood pressure that has to do with adherence to treatment, intensity, and also the interval until the next control visit. And the question that the researchers attempted to answer was, how can we reach 80% of control of those individuals with high blood pressure? And what they observed is if we continue with the current standard of care, we could only attain 46% control. To be able to attain 80% of control, we should have 80% adherence, 30% intensification of treatment, and follow-up within the 4 weeks. And also, to increase the intensification of treatment had the highest impact on attaining 80% control. That is to say, 80% control was attainable if the intensification of treatment reached 62%, even without changes in adherence or follow-up. What are the barriers to the intensification of treatment? First, in case of overburdened doctors, multiple demands for medical care, and the inability to provide care to specific problem, doubts in connection with the true value of blood pressure, that is when there is a difference between the values at the level of the hospital and the ones as outpatient, and also the therapeutical aspects, whether the person has knowledge about certain doses for certain medicines, and also adverse events, and also attributing the lack of control to lack of adherence as opposed to lack of follow-up, and an overestimation of its own performance and decisions based on time. That is to say, how often do we expect to ask the patient to come back to the office? And this is also another measure for intensification. What are the benefits of a protocol when facilitating the treatment? For example, if we look at heart, we have a simplified treatment with combined treatment, and we see that this diminishes the daily intake of pills. Also, it improves adherence to treatment. It also has faster control of blood pressure, lower exposure time to the risk. It facilitates team-based care, and also titration of medicine based on decisions made by the doctors. This has already been recommended in 2017 by the American College of Cardiology, and it has a high level of adherence, and it is also recommended in the new hypertension guidelines issued by WHO, where we see a recommendation to do so as long as the medical staff is properly trained and they can prescribe. They also have a protocol for the management of blood pressure, and this is also under physical oversight. Now, this factor, that is to say, team-based care with the titration of medicine by non-physical physician staff, has shown the highest drop in blood pressure as opposed to other techniques, as we see in this meta-analysis published in 2017. And in connection with this, we should recall that professional education could be a key element to generate trust in the health team and the management of medicine, and also control of adverse effects. And we could also, adverse events, and we could think of two key elements. What are the adverse events that are related to the doses, and when should a medication be suspended? But an important topic to underscore is that even establishing a sole protocol and also education systems supporting these protocols, even in those cases, we can observe that the rate of intensification of treatment by member of the staff could vary greatly, even within the same institution. For that reason, and if possible, collect data and disaggregate data based on the professional person, have yearly educational programs, have academic discussions with champions, advocates, and scientific societies, and also monthly meetings to be able to share the information within the organizations. Finally, how could we measure the intensification of treatment? We could use two indicators. One that refers to the time it took for us to initiate treatment after a diagnosis of high blood pressure, and this should be between 2 and 4 weeks as recommended by the World Health Organization guidelines, and the other one that indicates the level of increase or observance of a medication whenever the patient has values for blood pressure that are beyond the protocol. Thank you very much. Thank you very much, Gonzalo, for your presentation. It is very pragmatic. Please make a note. This should be the second question for your homework and debate. One of the key messages that we have after the presentation by Dr. Gonzalo Rodriguez is that we see that we have here a blaming game. Who should be responsible for the patients not to have the control of blood pressure? And doctors may say, well, patients are not following the recommendations by doctors, or they're not measuring their own blood pressure. But when we have serious studies regarding this, we see a very important element, and that is that the doctors do not increase the dose for the hypertensive treatment, even when it is needed by the patient and when the patient is not being controlled. So the doctors blame patients, and here we have another problem. So if what Dr. Rodriguez mentioned a minute ago is that doctors are too busy, that the work is just focusing on the doctors, and that our standard of care should be based on the doctor and the office, the medical office, then we have poor care, and that is poor teamwork. Whenever we have teamwork, we have a very relevant concept, so much so that the most successful hypertension programs in the world consider that this is the most important concept, and that is the concept of having nurses in those teams. And today we have the pleasure to welcome Carolina Neira, who is a nurse and is working in the cardiovascular program of Chile, and she's also part of the innovation group. Carolina will be referring to follow-up and how this could be done with the nurses. Carolina, please go ahead.
Adelante.
Please go ahead, Carolina. Could someone tell me what's going on? could someone tell me what's going on? Well, then this is what we usually see on TV. Well,
yes.
please go ahead.
Yeah, we have her presentation already on the folder. I think, Juan, please, could you upload the video?
Bien, estos tipos de cosas no suelen pasar todavía. Ojalá no nos pasara, pero nos pasan todavía.
We still face these issues. I wish we didn't have to face something like this. I hope you still have some patience, but teamwork is one of the key concepts in hearts. In countries that are participating for the first time and that are not quite familiar with our own working method, we can mention that this is one of the pillars of treatment. That means that we need to work as a team. And I was telling you that nurses are key, as well as other medical workers, such as the pharmacists and pharmacists, who are key for the delivery of the medicine and also the frequency of administration, the frequency with which the patients receive the medicine. So I just wanted to call the attention again of another group of colleagues that I have the pleasure to greet today. Please tell me in the chat who is participating and from where, but I would like to say hi to Mr. Lotto, Dr. Lotto, who is one of our main collaborators in Brazil with the Brazilian Cardiology College. The Brazilians are moving forward in the implementation of hearts, and they already have their technical guidelines for the implementation of hearts in Brazil. They have made some progress. They have not started yet, but they have made some progress. We also had the Family Medicine Congress recently, and we were able to present hearts. I see greetings from Guatemala, Costa Rica, Mexico. I have our colleagues from Chiapas, that is one of the states that is implementing hearts in Mexico. I also have colleagues from Guatemala, Costa Rica, Ecuador. Greetings from Bolivia and El Salvador. El Salvador, I heard, has made incredible progress, and they're almost ready with their care protocol, treatment protocol, and they will be starting with their treatment protocol by using the hearts model. That is another topic that we are trying to move forward. I understand that El Salvador may have a protocol ready in the upcoming days, and in a standardized protocol is one of the drivers for the control of hypertension. It is highly important because it guarantees that that work instrument could be used at the first level of care to facilitate the care of hypertensive patients, and doctors and the medical staff medical workers can continue with treatment. And I am being told that members of the statistics team are also working on patient care. They are in charge of follow-up. And this is what I hear from Teresa Ahumada from Ecuador. We are ready, I'm told. We're ready with Carolina Neira from Chile. Please go ahead. So this is one of the drivers for the control of hypertension in primary healthcare centers. And this has to do with the control and follow-up of individuals with high blood pressure. My name is Carolina Neira. I am a midwife and nurse in the Department of Non-Communicable Diseases with the Ministry of Chile. Today, we will be reviewing the literature on high blood pressure. We will be reviewing also the work conducted by Kaiser Permanente, and also see the measures of the performance of these elements.
Entonces ahora
En la
tenemos
revisión de la literatura,
In
muestra
reviewing the literature, we see the importance of immediate follow-up in case of high blood pressure and improving timing to control blood pressure also considerably improves cardiovascular outcome in randomized trials. And what do we see in our evidence? The less time it takes me to control the high blood pressure of an individual, the higher the impact will be on control. When it takes me less than 2 weeks in between the intervals of the controls, this person will be able to have more consistent blood pressure for a longer period of time. When reviewing the various comparative randomized trials, we can see that when I can obtain a blood pressure higher than 140/9 in a shorter period of time, the risk to have other cardiovascular diseases lower, such as a stroke and heart impairment, among others. In the next slide, we can observe the evolution of control with the various strategies with the Kaiser Permanente model. And at the beginning, it implements 2 medicines and then 2 drugs, and the follow-up of blood pressure is every 2 to 4 weeks with non-medical staff. What are the key elements for the medical follow-up of high blood pressure under the Kaiser Permanente model? First, we can mention follow-up every 2 to 4 weeks, and it is more efficient to do it every 2 weeks. To automate appointments, the appointment for follow-up can be established prior to the provider to see the patient, and also the need to measure indicators monthly, including clinical and nursing indicators. The care flow of the person that sees a doctor due to blood pressure is the following. The blood pressure is measured following 2 paths. One, the blood pressure of the person is on target, and the next control will be 3 to 6 months after that date based on the risk, and the other path is for the blood pressure to be beyond the target, that is to say, elevated. The doctor intensifies treatment immediately and determines the need for a follow-up appointment within 2 weeks. When the person goes to this appointment with non-medical staff to measure the blood pressure is measured as validated by the non-medical staff. And there are 2 paths. One is for the blood pressure to be on target. Therefore, the follow-up of the blood pressure will be every 3 to 6 months based on the risk the person has, or the blood pressure could be beyond target, that is to say, could be high. The non-medical staff intensifies treatment and also makes an appointment for a new measurement of blood pressure in 2 weeks. This cycle repeats itself every 2 weeks until the blood pressure is controlled. This is what we call a closed circuit, and we will repeat this until we reach the target. The guidelines of the WHO on hypertension 2021 indicate that upon commencement of treatment with antihypertensive drugs or modifying the treatment, follow-up should be monthly until the patient reaches the goal. They also suggest follow-up every 3 to 6 months for individuals that are already controlled or on target. The 3 topics, the 3 items to monitor in the continuity and follow-up of hypertensive patients as one of the drivers of control are: if the blood pressure is elevated, there should be follow-up within 4 weeks. Any hypertensive patient should have a follow-up visit of the last 6 months. The hypertensive individual who has a high risk for cardiovascular disease, including diabetes and chronic nephropathy, should have a follow-up visit within 3 months. The attainment of the items mentioned before should be higher than 80%.
Bueno, pareciera que tenemos problemas.
It seems we're having some problems to finish with this video. We can see the conclusions. I am going to help Carolina, and I'm going to read that the individuals who have hypertension benefit with shorter intervals. So the conclusions are the persons that are hypertensive benefit from shorter intervals between appointments when blood pressure is high. The immediate titration of hypertensive treatment improves cardiovascular results. If trustworthy follow-up system is key to improve care of hypertensive individuals as well as the quality of the health service provision. The attainment of, and this would allow us to attain optimal follow-up for high blood pressure. If we see high blood pressure, we should intensify immediately the treatment and also strengthen and reinforce educational content. Thank you very much. Thank you. This is a very interesting session with Carolina's presentation, and now I would like to invite Dr. Rodriguez Pressler and Dr. Carolina Neira to turn on their cameras. We're going to have some questions and answers, and I have some questions that were sent via chat. And this session almost gave me a heart attack. We had some issues with the video, and I thank you for the patience. And Gonzalo, I do not see Gonzalo. Please turn on the camera. Yes, I can see you now. So we have the 3 star panelists, and I have some questions. I am going to start with Professor Pressler, who is the dean of this session, the one who took us down the path of drivers. And my question is, when you started within Kaiser with this program that I understand it entails the constant improvement of quality, how were you able to have the medical staff to participate actively as opposed to reject all that was entailed in this project or program? Please go ahead with your answer.
Good afternoon, Pedro, and thank you. I'm not sure I'm a dean. I feel like I'm still a student. We need to continue studying what works, but thank you very much. So good question. How do we get the medical staff on board? I think the burning platform at that time was that we were really struggling with hypertension control. And if you look back at the slide that was shown previously, we were below the national average in spite of having an integrated health system. So there was a burning platform to make changes. And the 2 things we did at that time, which were most effective, were the creation of a standardized protocol with fixed dose combination pill and the creation of a follow-up system, as was described already. And just those 2 key processes alone made a dramatic difference. And as we continue to get data and give physicians their specific data, they bought into the program more and more. So as a general concept, physicians think they do a very good job with things like treatment intensification and control. And unless you're giving physicians their specific data, they tend to overestimate. So by creating a standardized quality improvement process with data drilled down to the clinic level and the physician level, you can then begin to make these very, very important changes.
Muchísimas gracias, Dr. Bresler, por este comentario.
Thank you very much, Dr. Bretler, for these comments, which are very important. But we have several countries that are currently managing their protocol. And you might recall, because you have been working with us for a while, but there is always some sort of resistance among the doctors. I wouldn't say that this is widespread, but doctors say, no, I would rather prescribe what I think is proper for each patient. You cannot talk about standardized protocol. I imagine you had something similar at Kaiser. And now that we know that this model worked, what would you say to lower the level of resistance among doctors, in particular, resistance to these standardized protocols of care?
Well, you have to continue to educate and to share data. Those are probably the two most powerful messages. If a physician's control rate is at 80 or 85%, they're doing a good job and you don't need to intervene. But if a physician is at 30 or 40%, they will be obliged to make changes in their practice. And if they're not comfortable with the changes, you have to educate. So are they worried about side effects or comorbidities or whatever the case may be? You have to work with them, typically with a colleague, a peer champion, go over cases and educate them until they're more comfortable. The second important point about treatment intensification and use of a protocol, we have found in our system that non-physicians actually do a better job of following the protocol. So part of our improvement was built on using nurses and pharmacists and nurse practitioners who the literature shows in many cases are more likely to follow the protocol and do a better job at controlling blood pressure. So education, specific data, and then creating a team-based approach, I think are key moves.
I'd like for you to take notes what Dr. Bretler just said. We are working on evidence, but we are also giving you an example that of a system that has 80% control. And just to remind the audience, Dr. Bretler, do you know the percentage in Latin America of individuals that have controlled blood pressure? Only 35% among women. 35% among women and 23% among men. This is already showing that we have a program problem. The way we are leading, we are implementing this, because medicines may have different from here and there, but medicine drugs don't seem to be essential here, rather the way we're implementing the program. Gonzalo was also referring to the combination of fixed doses, which has been key for treatment. But now I am going to give the floor to Gonzalo in connection with the problem that Dr. Bretler just mentioned. Gonzalo, what do you think about the therapeutical inertia? You talked about it. Why is it that we see these resistance among doctors to increase dosage as opposed to doing it when they have to do it, and we continue with this inertia in treatment? Please go ahead, over to you. Thank you, Pedro. It is a very good question, and I wish I had a specific answer in connection with the specific problem to tell you, well, this is the problem, and you need to face the problem this way. But I think that therapeutical inertia has several angles that lead the doctor not to intensify treatment. For example, among those patients that do not attain the control targets that they need, and they need to have higher or more intense treatment. And one of the key factors, undoubtedly, or we can break it down into system factors. As we mentioned in the presentation, if they are overworked and there is a doctor, as we see at the primary care level, that has to see several pathologies that goes from pregnant women to hypertension, children, and they need to have their head and energy devoted to several pathologies, several conditions, and sometimes they devote less time to investigating or researching the specific cause of a problem. And that could be to talk to the patient, to talk about therapeutic adherence, whether they are taking the medicine the way they should take it. And I think that the other key factor has to do with the level of knowledge. As I said in my presentation, the level of trust we may have based on one's knowledge, based on what we learned with the passage of time, and that has also, and a person who has always been working along that path and knowing what adverse effects to expect and how to manage them. But sometimes with practice, we lose a wider perspective or to look into different options for a schedule of treatment. So that could be useful, but we need to train, we need to educate, we need to support to give them the tools as to where to find the solution. And I think that this is what will allow us to reduce the therapeutical inertia. That is to say, the distribution of tasks in the medical staff and also tools and information to overcome the lack of knowledge. Thank you very much. We're almost ready to move on to a different chapter, to a different section. Do you know the percentage of individuals that have hypertension? About 40%. If we were using a lower level, or if we were using what the WHO guideline says, that is to say that if you have a pre-existing cardiovascular disease, if you have, or if you've had infarction, myocardial infarction, or stroke, if you have diabetes or chronic kidney disease, that should be below blood pressure should be below 130. So we have low control levels and high pressure is widespread in the region. So can we maintain a health system when the doctors are the only ones that can follow up the patient even under control? If we have a treatment protocol, why is it that the nurses are not more active in this?
But Carolina, the truth is that laws and regulations of many countries have lagged behind on this issue, and they do not help us out. So I would like to ask Carolina, how do you see this from the nurse's point of view? Carolina, please. Thank you, Gonzalo. Good afternoon, Pedro. Thank you so much for your invitation. Yes, the Chilean legislation and in other countries does not really support us legally to increase treatment, but it does support us to follow up standardized protocols that have been held up by evidence. So each country has to discuss with the ministries of health how, through a standardized protocol, the nurse could intensify the therapy because it is something that has been delegated to them. In nursing, there are two areas. One is nursing activities and also delegated measures. And if there is a protocol, then there would be no difficulty in training, and the nurse practitioners that exist in the United States who do have the necessary training to increase dosage. But it is also true that country should not be paralyzed saying, well, the nurse cannot intensify treatment and that's all I do. We have to continue looking for other strategies, for instance, shorter medical control, which we are implementing in some services, so the nurse checks, and so we do not let people go home with high BP. Each contact we have with the patient is a possibility to compensate the patient. If the patient goes away, it's likely that he will not return. So the person cannot go back home decompensating, because then it will be a time bomb. So do not be paralyzed. Please protect yourself with standardized protocols, which must be validated by each country's authorities, by the doctors or scientific societies. And with that support, the nurses and pharmaceutical can do that. But let us not stop there. Let us look for other strategies while we wait for the legislation to progress. I think this is very clear, and we can also sell, and let's see if the panelists agree with me. In the countries where the participation of nurses, of the nursing profession in general, is more active in a program such as this one, it is more likely that there will be quality in the follow-up of patients and timely treatment. Gonzalo, fortunately for hypertension, we have drugs which are quite sure they are really safe drugs. We know what we need to do. Nevertheless, truth be told, our control levels, and I would like to use a word that is not very beautiful, our control levels are ridiculously low. We have very low control levels. People are in the street with a huge problem that kills the highest number of people in the region, that produces most events and handicaps more people and consumes more economic resources, and it's called hypertension, and we're not doing what we should be doing, although we know what we need to do. So we're going to have the hypertension drivers. We need to do something. We really need to do something about it. We need to have a more intelligent program, not just a wish to change things, but to know when things need to be changed. I will now give the floor to Jenny, because there is another issue which has been mentioned. In the when cardiovascular risk assessment is essential to define the treatment target for patients and the frequency of intervals. So, Jenny Rodriguez, we are going to go to the second section of this webinar. Thank you to all the panelists. I thank them for their presentation. Jenny Rodriguez, please, you have the floor.
Muchísimas gracias, Jenny, por este material.
Thank you very much, Jenny, for this material. I would like to say that the risk calculator, I would like you to please put the link on the chat for those who have not downloaded the card calculator. Nowadays, there are 48,000 professionals who are using this calculator. You may think that 48,000 is not a large number. I would say, no, it is not, because we have 48,000 people who are using this risk calculator, And this is a vital instrument today, not to decide who will be treated, because that is pretty clear with the existing WHO guidelines, but to know which is the target goal and how frequently I need to follow up the patients. In the second section, we were told how important are the hypertension control drivers, but now we're going to see how we can ensure that this will happen. What must be done in order to implement this? So during the second section, I will introduce Dr. Gloria Giraldo, who will tell us how can these key control drivers, which can be assessed by the countries. So we will give the floor to Dr. Gloria Giraldo. Good afternoon, everybody. I am very pleased to be with you today and to present this next section. Let me know whether you see this presentation properly. We are going to speak about improving quality. How do we translate these control drivers into measurable action? How are we going to monitor this? I have been reading the chat, and there are a lot of persons that are joining us for the first time, and I would like very briefly mention that the Hearts Initiative in the Americas is the result of making operational the technical package of HARS, which was published in 2019. In WHO and in Paajo, we were proposing that via this theory, we were going to try to reduce cardiovascular diseases and premature deaths through this model. And this is the model that was presented to us. The high blood pressure, diabetes, the patient comes to us through primary health care, his cardiovascular risk is assessed, then we apply the technical packages which are available, but there is always the doubt about how to carry this out. And those mechanisms to obtain this. And how can we do this? By proceeding in a very intentional way with quality processes. Quality is really a life or death issue. Let us look at some very interesting data from the Commission for Systems of High Quality, which presented a report with an estimate of deaths caused by inadequate health care. 8.6 million deaths at the world level, of which were classified 3.6 million because people did not have access to health services. But something that is even of greater concern is that 5 million deaths were of people who did have access, did use the system, but nevertheless, they received low quality care. And in this graph, you can see that these studied conditions, cardiovascular diseases, were 33% of these deaths, which could have been taken care, and 1.4 million deaths were due to low quality of health care. So this is why quality is really a life or death question. We are going to use the cascade concept, which is a concept which is used for other conditions successfully, as in HIV, and it is very useful for hypertension. I will show here the results of two very important studies which have used different methodology, well prepared by different authors. but they have the following thing in common. When we see who suffers from hypertension, who is aware of the fact that they suffer from hypertension, how many are receiving treatment, and how many are able to control hypertension. We can see that in both studies, one from 2016 on the left and the other one of 2021 on the right-hand side, the segment of people who live with controlled hypertension is very low. In each of these graphics, we see that there is a great opportunity for change, an opportunity to improve the quality of care, and that is what we try to do. When we look at the global data, we can say, well, that is at the world level, but we do have the information for our countries. We have the same cascade on hypertension for our countries, and only taking a panoramic view of this slide, we can see that there is a lot of space and possibility to make improvements. All the materials will be at your disposal, so you may study in detail the cascade of hypertension in each one of our region's country. As you will see, there are great possibilities for improvement. How do we use this cascade concept? You can see that the drivers mentioned by Dr. Bretler are the key improvement points if there is a continued quality improvement process. There are steps which can be taken in each one of the stages of this cascade. This is one of the advantages of characterizing the process followed by a patient, for instance, throughout this cascade. In the lower part, we see that this is all based on teamwork, and everything has to be monitored. The whole process must be monitored. We also see where the drivers are for each stage of the cascade to attain the desired outcome. In this process for quality improvement, we have not defined what is the quality management. There are many definitions of management quality. We have the WHO definition that states that quality in healthcare is the grade in which the health services for individuals and populations increase the probability of obtaining the desired health results. There's another definition which I like because it says that management is defined as the combined and continuous efforts of all the healthcare professionals, but it also includes patients, families, researchers, those who pay in a health system, planners, educators, in order to carry out changes that will lead to results in health, to better performance and better professional development. With these definitions, let us use one of the classic models in quality of healthcare, which is the model of Professor Avedis Donabedian, who is the grandfather of health quality. He said that quality indicators were classified as indicators for structure, process, or result. Structure, physical and organizational characteristics where the healthcare is provided, the process, which is what we were talking about today. Dr. Gonzalo and our colleague Carolina were speaking about those processes during the care of the patients in order to obtain the results which are the effect that we are trying to attain in the health of patients and the population. Let us leave the theory and use a tangible example. The 325 persons that are attending this webinar now, let us plan a trip via the Pan American Highway. And our first step is to choose our target. And our target is to arrive to the land of a high coverage of hypertension patients and control hypertension. In order to do that trip, and we have already chosen the highway, we now need to find the structure, the vehicle that will bring us to our goal, and we need to be aware of all the processes and mechanisms that would allow us to get there. We also have tools such as the GPS and the map. So those are the elements that allow us to measure, and they will tell us what is the tire pressure, what is the engine temperature, what is the condition of the brakes. We need to monitor those processes. And this analogy is something that we wish to continue to use to show that the 8 drivers working with Dr. Brettler from Kaiser Permanente and the Innovation Group, we have already carried out that task in order to facilitate this and in order to boost your programs. So what I'm going to do now is to present the models that we can use. We already have the theoretical basis in the continuous quality control improvement, and one of the most used models is the model of Plan, Do, Study, Act. It has the name of the steps of this virtuous circle, which starts when a team of primary care asks itself the following questions. What are we going to improve and how much? By how much? How will we know if a change is an improvement? And which changes can be done in order to obtain this improvement? In order to attain it, this group studies, plans, determines targets, and develops a plan. And then it goes to action. And this is where we saw which drivers, which aspects. Carolina, for instance, was talking about follow-up of patients. Dr. Gonzalo was talking about the treatment protocols. Does it exist? Can it be improved? Each driver provides an opportunity to apply a short planning cycle of plan, do, study, act. And we have an additional help here, which is the scorecard. This scorecard includes the 8 drivers which have been sharing with you today. And in addition to that, we have the recommendations of how we can attain improvements for each of these drivers. If we need to improve the precision in the measurement of BP, we need to certify and make sure that health professionals have been trained in the technique of BP measurement, and this has to happen every 6 months. We also have tools, and this is linked to tools which can help you in your health centers to attain it. The scorecard also contains targets, which are high targets. Why? Because this quality issue is an issue of life and death. So the Innovation Group, agreed in recommending high targets and also There are scores, that's why it's called a scorecard, the frequency of provision of information and the type of indicators with regard to the frequency and who will this data be provided to. This data is for the same primary health care team. This is the only way we will be able to get changes done. The people that are providing care should know. We tell patients that they should know their numbers. We want you as health professionals know your scores. You need to know how you are performing. And for that, we have two indexes. An index for the maturity of implementation to guide the quality improvement process. And based on the scorecard that I have just showed you and the scores, you will define the levels of maturity. Level 1, where everything is yet to be done to improve implementation, to level 5, when it has been possible to really take these drivers to their maximum capacity and there is a maturity in implementation. The second index is the performance index. From the very beginning at HARS, we have had two key indicators, which are the target. That's where we aim to go. Coverage and control. Coverage represents the capacity of a system to detect and treat people in the population who suffer from hypertension. And the control is the measure that reflects the quality of this service. If we apply this, we will be able to improve the quality, and this will result in a better control of our patients. Both indicators combined, coverage and control, show the success level of a program and its effectiveness. And we have here the scores. If the performance is low and there are great opportunities for improvement, if it is starting, if it has progressed, if it's high or excellent, that is where we want to arrive. So we invite you to get on board this bus on this Pan American highway trip to look for an improvement of quality. And we have our valuable resources. The most valuable one is people. We need to improve structures, processes, and we have the tools. We are all responsible for improving attention quality. Thank you so much. Thank you so much also for this drawing that you showed us at the end. Gloria's presentation is very interesting. As you know, Gloria has joined Hearts at Paajo HQ. I do not need to introduce her because you already know her, but she has shown us how we can carry this out in the practice. And let us see whether the innovation group had the mission to try to keep their feet planted on reality. And they were saying, well, if we have goals which are not challenging, then it is possible that nothing will change. But since we saw that the situation was so dire and there is such a huge gap to be covered, we had to find another way to do things. But even so, there is always a concern as to how are we going to take the next step. And for this reason, today, it is my pleasure to introduce Dr. Chanasi, who is the coordinator of Hearts in St. Lucia, and she will tell us what is the idea that they have when a country receives this. These are the drivers of hypertension controls, and this is how we're going to do it. Welcome to our webinar, Doctor. Please present the reaction of one of the implementing countries.
Good day, everyone.
Go ahead, please.
My name is Shannon Sue Filbert, and I am the Senior Medical Officer for Non-Communicable Diseases in St. Lucia. I thank the webinar facilitators for allowing me this privilege to share with you today. St. Lucia launched the HEARTS technical package in October 2019 and officially started the implementation in 6 centers in January 2020. In a sense, our timing seemed bad, while in a greater sense, given the impact of the pandemic on NCDs, including hypertension, we couldn't have chosen a better time. HEARTS has opened a window of opportunity for St. Lucia. Today, I will briefly discuss with you 1. What activities St. Lucia has implemented to improve hypertension control, and 2. What we've learned through the process. Over the past 2 years, as a result of ongoing collaboration with Paajo and technical support, we have been able to strive to adopt fully or partially most of the HEARTS drivers using a stepwise approach. While a very rewarding process, I must say, there continue to be challenges. In this slide, you will see the 3 drivers we have fully implemented, the 3 drivers which are being implemented, and the drivers we are trying to implement but still encounter challenges in terms of complete implementation and evaluation. Treatment intensification will be followed up soon through our electronic hypertension registry, which is about to be rolled out in all primary care centers. Prescriptions are valid here in St. Lucia for 90 days, but unfortunately only 30 days worth of the drugs are given at a time. And this is an ongoing issue. We are yet to be able to change this. This is an example of the current workflow, which highlights the task shifting and the involvement of the non-physician healthcare workers in the care of the hypertensive clients. What is there to say about relevance of the HEARTS hypertension control drivers? I will say that there have been many positive changes. In terms of blood pressure measurement accuracy, there is a heightened awareness of the importance of accurate blood pressure measurement amongst the staff. There's an improvement in the repeat blood pressures, which are done when the initial blood pressure reading is high. There are changes in the healthcare facilities. There is now the use of a quiet room to measure blood pressure. There is also widespread use of validated monitors for blood pressure measurement. In terms of continuity of care and follow-up, there are more frequent follow-up visits with patients presenting with medication, which only helps target adherence issues, which is great. There's performance evaluation and feedback. That has caused improved and prompt feedback from providers regarding challenges, example, stockouts, malfunction of instruments, the availability of pharmacists on clinic days, which is a sore issue, and the availability of fixed dose combinations, which the physicians prefer. There have been more frequent team meetings, as I had mentioned previously. And right now, I'm so happy to say that there has been the acceleration of our electronic hypertension registry, because everybody wants to be able to get that information and be able to use that information to get feedback to the team so that they could see what they need to improve. So right now we about to roll out our registry, and that will help us with monitoring our control, which we're already doing, but also looking at how the protocols are used, looking at whether cardiovascular risk is assessed for every patient and so on. So we're very excited about that. The implementation of the drivers allows healthcare workers and policymakers to systematically identify and target barriers to blood pressure control and to adopt relevant quality improvement measures to address such barriers. The HEARTS drivers are really the way to go. Thank you.
Sí, yo creo que perdimos la comunicación ahí
Think that we lost connection there.
Por favor, Jenny, me indica
Jenny,
que me
could you
quedé sin
please
señal.
Tell me, I think I don't have any audio. No. She's over with her presentation. She finished. I apologize. So here we have another way.
Y ha estado participando activamente en el grupo Innovación. Le pido a
Jen has been participating in Janaciria and Gloria Giraldo. Please turn on your cameras. We will be moving on to questions and answers. Shanna just came to an abrupt end and I didn't know whether she had concluded her presentation or not. But I understand that we are live and that it is difficult to coordinate each of the details. At any rate, we heard very interesting concepts, for example, how we react to the issue of quality. And clearly we have questions for Gloria as well as Shanna. Gloria, you said that the issue of quality was a serious issue, and in passing, of course, you cover several topics, too many, but you said that heart had two main indicators of performance. That was the program coverage, and another one that was the program control, that is to say, control of hypertensive individuals and control of hypertension. And clearly, the low level of control referred also to the quality of the system of a health system, a program that is having issues in finding the minimum standard of care. Would you like to address this? Yes, clearly. One of the comments from the outset with hearts is that when we arrive to a new country and we ask health professionals at a specific health center what their coverage was, first, many did not have an I answer. Next, some said, well, I saw a panel of 100, 200 patients, or I have 500 individuals with hypertension at the center level. So the question went beyond that. In your jurisdiction and based on the estimate of prevalence, and for the ones that in theory you are responsible, how many of those are coming? That is to say, what would be the coverage? Has the population for which you are responsible been covered by this? And that's why we're referring to coverage. It is the capability that the system has to work to include those individuals that should be included in those systems. And the second indicator, control indicator, as the name indicates, is once it is within the system and under their care, they are attaining control. So now we're going a step beyond with the creation of this index that allows us to summarize the effectiveness, to be able to combine and receive a score based on the level of coverage obtained, and also a score based on the control among the patients in general and high-risk patients. And that measurement summarizes the performance index. And the maturity index is based on all of the drivers that we discussed. And clearly, this is more of a detailed discussion. And we are going to invite people to the virtual course on drivers for hypertension control that will allow them to study the index and allow them to use it. I think that this is a key topic. You presented a slide that included each of the countries of the Americas, and I think that this is something that should be communicated, because most of the problem we have is that people do not know that they have high blood pressure. So that is the problem. We have a lot of people walking along the street that have high blood pressure, but they do not know. It means that the system, the health system, has not found the ideal mechanisms to make sure that people go into treatment and get diagnosed, and the other percentage has to do with the level of control and the quality that a system offers to be able to attain this. So I think that it is very important to continue to confirm this, but now I will move on to Shanna. Shanna, you know that crises also lead to solutions. A crisis is an opportunity for a solution, and I wouldn't like to go through another crisis such as COVID. I'm not saying that we're not going to go through this again, but I'm saying that COVID has been a stressor for our health systems, and it pushed our imagination beyond limit. But in many areas, I understand that we cannot give individuals medicine for 3 months because they were given medicine every month and people had to go to the pharmacy, and then they needed to have their blood pressure controlled. And we understand that this is another solution that has been offered through COVID, the COVID period. How are you facing this in St. Lucia? Are you going to still have telemedicine and also delivering medicine ahead of time? Are you going to continue to follow up through non-medical staff? Please go ahead, Shanna.
Thank you, Pedro. Good afternoon, everyone. I think you're right, Pedro, that on every level we've learned so much from COVID. COVID has been a negative experience for us. However, we've learned. And one of the things we've done in St. Lucia was realize that we really needed to pay attention to was the fact that patients need to be in control of their disease. They need to be very educated. So we spent quite a bit of time during the pandemic looking at self-management. So we have reinforced our self-management program, our Stanford self-management program. We also published little booklets on management of hypertension, diabetes, our chronic care passports, and we got those, we had some sensitization, got those into the hands of the patients. We've also been getting our healthcare providers to teach patients how to monitor the blood pressures at home using validated monitors. So we disseminated that information as well. One of the things that we have been seeing increasingly is that patients are actually measuring blood pressures at home, and it's because the providers are ensuring that. But I think for us, in terms of hypertension control and diabetes control, COVID has taught us that we really need to zone in on self-management and education. Thank you.
Excelente, excelente, Shanna. Shanna es una de las...
Excellent, Shanna. Shanna is one of the members of our team that is always ahead. That's why she's part of the innovation team, and she was selected to present what her country is doing. I am going to share a final message, as I usually do at the end of each session, and I think that we need to communicate a very strong message that hypertension control is at the first level of care, Shanna. We are not going to do it anyway, in any other way. It is important to know what the instruments are, and also the teams and the individuals need to be ready to care for their patients in the best possible manner. And you may have remembered what Gonzalo said. We need to teach doctors, and we have those at the first level of care who are responsible for this. And for that reason, in the third section, we are going to be introducing the course that has been outlined. But before that, we are going to take a break with St. Lucia to show you that heart is in St. Lucia with the energy and the happiness of the Caribbean. Thank you. Thank you, Shannon. Thank you very much, Gloria. Please go ahead.
It's good for the heart. Somebody say it is for health, it is for health. Give me the E for energy, E for energy. A is for all our way, A is for all our way. Give me the R for ready, R for ready. The T, the S, take the test. The T, the S, team no stress. H-E-A-R-T.
esta pausa nos vino de lo más bien para tener una pausa activa.
This break was great to be active in the break, but also I was concluding the previous period by saying that we need to train all of our workers. And now we are going to be presenting in our last block a virtual course from the hearts community. The courses are offered here at Paajo for everyone, but let me remind you that we have more than 80,000 attendees to our courses, and the surveys are extremely satisfactory that this type of course is being useful to generate knowledge and changes in the conduct of the care teams. So now I will have the presentation of this new course, and Jenny Rodriguez will be presenting it as coordinator of our training unit. Jenny, please go ahead.
Good afternoon, everyone. I'm Dr. Jenny Rodriguez, and it gives me great pleasure today to present you the new virtual course on hypertension control drivers at Permanente healthcare centers. This course is a training and learning tool, and its primary purpose is to improve clinical performance and quality of care. It is part of the learning resources of the HEARTS initiative in the Americas, and it is built based on the best accumulated experience with the participation of experts from the Innovation group. The course is especially recommended for primary care physicians, nurses, pharmacists, and allied health professionals working in the first level of care and interns. In addition, professors of health science programs, including medicine and nursing, are recommended to embed the course and make it available for their students or incorporate it into their curriculum. The course is organized into 8 modules, including a special module on COVID-19, hypertension, and cardiovascular disease. An initial brief introductory module is designed to show participants the main successful experience of hypertension control and the major driver of hypertension control. From Module 1 to Module 7, the course is structured into a brief main presentation of about 15 to 20 minutes, an interactive clinical exercise, and a short evaluation. Module 1 is an overview of quality improvement. Module 2, accurate blood pressure measurement. Module 3 is about medication titration, and it shows the importance of using standardized treatment protocols for hypertension control, how to measure treatment intensification, and task shifting strategies to improve blood pressure control, as already well described by Gonzalo. Module 4 is follow-up blood pressure check, nicely shown by Carolina in her presentation. Module 5 approaches the major process measure and the new HEARTS scorecard and how to use the scorecard as a quality improvement tool to improve blood pressure control. Module 6, Community Outreach, assesses the importance of screening all patients for hypertension upon clinic entry, the diagnosis of hypertension using standard criteria, and the search for undiagnosed hypertensive patients already seen in the clinic, among other objectives. Lastly, Module 7 addresses the importance of home blood pressure monitoring in the diagnosis and management of hypertensive patients. Now, my colleague Carlos from the Paajo's Virtual Campus of Public Health will show you how to log into the platform and enroll in this wonderful new course. We are very grateful for Carlos' work in putting together all the material provided into the platform. Go ahead, Carlos. Thanks.
Thanks, Jenny. So, how do you access the course in the Paajo Virtual Campus? This is how the platform looks like. You can see the website of the campus at the top of the slide. You will need to press the Create Account button if you don't have an account. If you already have an account, you can just log in. Then click on the Self-Learning Courses section at the left side. This will take you to the list of all the self-paced self-learning courses of the campus. Click on the image of the Hypertension Control Drivers course. After participants review the course contents, complete the module activities, and pass the quiz of each of the modules, they can fill out the VCPH quality survey and download their own certificate similar to the one that you see on the screen. And of course, if you need any assistance, you can contact us in our help desk. Thanks and enjoy the course.
Thanks, Carlos. We invite everyone working in the primary healthcare setting on the hypertension control program to familiarize themselves with the virtual course. Enjoy the ride and thank you so much for your attention.
Bueno, muy bien, excelente. Jenny,
Very well.
Carlos.
Thank you, Jenny, Carlos.
El resto de los panelistas.
And the other panel members were reaching the end. Dr. Bretler, Dr. Gonzalo Rodriguez, Carolina Neira, Dr. Giraldo, Dr. Shana Schill. Please turn on cameras. We are reaching the last segment of this excellent seminar. I would like to also see if our colleagues from the innovation group are connected. Jenny, this course first. Jenny Rodriguez, this is a course that is available in English, correct? It is open, so if you go now to the virtual campus, you can have access to the course, correct? When are we going to have this course in Spanish? Thank you very much. This course is available in English. We have shared the link in the chat. We are producing the one in Spanish. We do not have an exact date of the final production. It depends on the technical aspects, but we will also be publishing the web link on the Hearts webpage. So we will upload it soon, starting next year. Jenny, we have 80,000 attendees, 80,000. 80,000, 80,000 attendees who are participating in the HEART courses. We are happy because the courses are being used, but if we want to transform the first level of care and offer powerful courses and make them pragmatic, we need more information, more people working on this. So I invite you to visit the virtual campus. We have some examples of countries. Jenny, would you like to give some example of some countries that had a very good performance with these virtual courses? Mexico, Ecuador are some of the largest examples that we have in terms of successful and academic success and academic results, and also webinars and dissemination of information. Mexico has been working incredibly well to try to reach out to each of the providers at the healthcare centers, and they are also working with centers that are implementing HEARTS, and that is our main mission, because we know that they are the ones who are implementing HEARTS, that is to say, the ones that have the task of becoming familiar with the way it works, and virtual courses are clearly a guideline, a guide to show how HEARTS is structured, also how to properly measure blood pressure. So everything is aligned with the new guidelines on BP management according to WHO. Mexico is working with the scientific societies and medical societies, and that has also made it easier for everyone to be part of this team. Mexico is reaching 35,000 participants only over the last couple of days. And let me conclude by saying, please do invite your colleagues, spread the word. This is a recorded webinar. We upload this to YouTube as well as to HEARTS webpage on the Paajo webpage. Please do show the link, HEARTS link, so that you can see the material. All of the material will be there, all of the recorded material. And finally, I give the floor to Dr. Jeff Bretler, who is the mastermind behind this. I think that he is the coordinator and the person who is behind this, the one that is giving us the full vision. We do have the course, we have the webinar, we have the videos, we have the virtual course, and we also have a paper that is underway. We have completed the production cycle of a product of this level, and based on the experience of what you have seen at Kaiser Permanente, how are we doing here at Hearts? What do you envision for the program? Go ahead, please.
Thank you, Pedro. And first, I just want to reiterate my thanks and appreciation for all the representatives of the Innovation Group. It was a wonderful collaborative effort amongst 12 countries with terrific input, and it really was the impetus for the creation of what I think is wonderful work that I think should really serve everybody well. You know, control of hypertension continues to be a problem everywhere in high-resource countries and in lower and middle income countries as well too. But as I stated earlier, we have the tools. We know how to get this done, and we think the next step in really moving control forward is to understand what the key drivers are. And the Innovation Group, from an evidence-based perspective, has really identified those key drivers. And if we begin to focus on these drivers and to measure them and to give feedback to clinics and providers, I'm very confident that the control rates will start to improve. It's just going to give us that many more tools to really make a difference in the care of our patients. And the other important thing here is that the WHO guideline now really reinforces everything that we're doing. So there's wonderful evidence support and now wonderful guideline support for all of the work that we're doing. So starting with control, but then looking at all of your process measures and your key drivers, I think is going to lead all of our countries towards a much higher control rate. And thank you again for the opportunity to participate in this event.
Muchísimas gracias. Con estas palabras estamos cerrando.
Thank you very much. With these remarks, we are concluding another webinar. I would like to thank the interpreter for their fabulous work, fabulous. And I would like to thank the administrative team that is behind this production, the company that is Team UI, the company that is supporting us with the production of these webinars. And please turn on your cameras. We are going to take the final picture, the panelists, and we will be seeing each other soon. We will be hosting another Hearts webinar to continue to move toward the shared goal of controlling hypertension and reducing the extreme burden of cardiovascular diseases in our society. Thank you to the panelists, congratulations to them, and to the production company. Thank you all for this excellent webinar. This is a strange webinar. Now we have twice as many participants as we had at the beginning, so it seems that people leave, but here they keep coming. Almost twice as many, so it is quite interesting how people have reacted. Thank you. Thank you. Have a good rest of the afternoon, good weekend, and please take care of yourselves. COVID is still among us. Thank you. And the last segment, please go ahead.
Jenny, también en portugués, ¿no? Muy bien. Que después nos digan los brasileños que no tienen materiales en portugués.
La gente no se quiere ir, se quiere quedar con nosotros. Siguen 230 personas conectadas. Qué lindo, muchas gracias. Un viernes en la tarde. Gracias a todos. Felicidades.